Well, thanks to these three panelists for each extraordinary talks. And now we have 10 minutes for questions, and if people will go to the microphones and just, again, identify yourselves, please.
Hi, Lauren Sipley. It was a great panel overall, but I have a very specific question for, apologize if I mispronounced Tergay. Is that how you say your name? Yeah. It strikes me with the scale-up that's happening in Norway and in combination with the administrative data sets that I know that Norway and similar countries have you started to look at policy-relevant impacts? Because my guess is from your intro that that was really what you care about. It's psychiatric disorder, diagnoses, healthcare costs, incarceration costs. Have you looked at that long-term?
Is this on? Yeah, okay.
Yeah, it's on there.
Yeah, we have looked at some of the public health indicators in Norway over the years, and some are pointing in a positive direction. But of course, the question is of causality, because we had a drop in law-breaking behavior among youths, and some of our research colleagues said that's because of the iPads. You know, the kids are so interested in iPads that they don't do any crime. And we think it's because we do a great job by preventing these kinds of behaviors. So yeah, we have some positive indicators, but we have a hard discussion about what are the causes of these drops.
So because you did all these randomized trials, though, can't you link, since you have large data sets with individual indicators, can't you link the trials and to long-term outcomes, or no?
No, not causally. But of course, we can look at the timelines, you know, that as we scale up our intervention, we can also see if there's a parallel drop in some of the problems areas, and also if there's an increase in, for instance, attending schools and whatever. So we're in the process of that, so we have a couple of grants now looking into the registered data to see if we have some positive impacts of all these interventions.
Good morning, Felicia Bowen, Rutgers College of Nursing. First I want to say, great morning, great panel, fantastic keynote. And my question is for Amy Weatherby. Amy, I think that what you're doing is absolutely critical, and I work in an urban community where we're pushing for preschool, but more importantly, trying to get early preschool in. I think your presentation really demonstrates that waiting until a child is 3 or 4 is way too late. And so I'm very concerned about, you have these instruments and we have this wealth of knowledge, but we're missing a whole population of kids. Technology is great, and I think we do need to use all forms of technology, but when we do this, I always worry about creating an even greater disparity gap in health because, yes, people say, low-income folks have phones. Well, they have phones for maybe 2 days until the number runs out, or they have minutes for only a little bit of time, and they're not using them consistently. There are no computers in the home. Parents that are impaired, that may be so incredibly depressed. I was looking at the one mother trying to engage her child, and I thought, I see children trying to engage their parents, and the mothers are just so numb in clinic, they can't even respond to them. And is that behavior having an untoward impact on the child? You have a baby trying to engage the parent's not responding, so then I just stop engaging. So
that's a good question. Yeah. Let's give Amy a chance to answer it.
Yeah, outstanding question, and I think you've really put your finger on the many, many challenges that our nation faces, and I think if we don't put our heads together to really solve this, we're missing an incredible opportunity. I think the technology can reach the families that you're describing, I can show you many videos of moms or dads who are very depressed. Part of it is because their child is not, I mean, there's this transaction. It can be child-driven as well. And then that keeps the cascading and impacts the child's development. So if we can get in early, I think that we can turn it around for the mom so that it becomes enjoyable. Now, we have many home visiting programs for low-income families or families who are at risk. So what I see is this opportunity that the technology can train very cost efficiently the home visitors, and that Part C can help to support this home visiting workforce that we have for families at risk. So the technology is not only for the families. I do think it plays an important role because I'm not completely confident the professionals are going to lead the way. But I think it's this whole many silos of programs that serve not only low-income families but families at risk, which we can provide the professional development to them, but getting in really early. And I think we've got the mechanism to do it. What I see as some of the missing pieces are the professional development and the collaboration, which shouldn't be that hard to accomplish. Now, in terms of the technology in the home, we need to make that available. Think of it as nutrition for our children. And so I think in research, we can easily build in funds to provide the connectivity to the home. But I don't see why we can't do that as a nation as well for our low-income families.
Thank you. Thank you very much. And I'm going to take the prerogative of the chair to ask Dr. Ogden a question that I'll ask him to answer when we've had these other two panelists. I've often been in Scandinavia or in Costa Rica or other places as the outsider, the American coming and looking at these systems. And I just want you to reflect, as a Norwegian looking at the American system, what do you think are the biggest differences? Where are the opportunities? And where are the obstacles we face in broad-scale implementation? Next question. I'll come back to you at the end. And I have a question for each of the panelists. We probably won't get through them. Go ahead.
All right, I'll try to be quick. I moved to this side of the room so you'll think I'm somebody else and I'm not hogging the mic. My question is also for Amy or Ann. Do you specifically, in your intervention, do you specifically teach or encourage parents to teach others the skills that they've learned so they can kind of generalize outside the parental environment? And or do you collect any data to know whether that's just happening naturally?
So that's a great question. Are you the one from Pennsylvania? I can't see that far. Just so you know.
His name is Mark.
Mark, is it? Brian, right?
Brian.
Yeah. Brian, okay. So just so you know, Pennsylvania was one of the founding states for Autism Navigator, so it's rolling out there. We're very excited. So they helped fund us at the beginning stages. It's dangerous to have a mom train a dad, for example. I mean, so we actually guard against that. We encourage multiple family members, extended, whoever the family wants to, have to come to our sessions to teach. I think it's very tricky to teach others to do this. So I think at some point we're going to be creating certification process, and I think it takes a good 9 months. Well, our data shows that in 2 months the parents start to implement the strategies. So they're starting to learn it in 2 months, and by 6 to 9 months we're seeing child outcomes. But I don't think in 9 months of going through the training we would expect the parents to be able to train others. So I think down the road, we were thinking more of professional certification, but if parents are interested in then learning how to train others, that would be great. I think it could add stress to a family who's already stressed by having a child with a disability to have like the mom teach dad. That's often not a good idea.
I was thinking more the example where the mom continued to use these strategies until at age 5,
right?
And now the child is entering school. Does the school have these this capacity?
Yeah, so that's a great idea. I think by the time that a mom has gotten to that point and is showing sustained use, then they're very empowered and they're going to be able to go into the school and help others. So I think we could harness this really well, but we have to do it carefully in the early stages of learning.
Yeah, thank you very much. Last question. Dr.
Ron
Ogden.
Prince, USC East. This is drummer time. Brian and I are both drummers. My question, I'm sorry to direct only to Amy, but I know all of your work and I'm very impressed. Amy, first of all, I wanted to say that what you presented as a whole system and model is the best thing I've ever seen in autism since I worked with Ivar Lovaas many, many years ago. But my question for you is to broaden beyond, to link it to some of the other things going on with parenting support. Just like children need to be mainstreamed, there's a notion that parents, for parenting support, not for the intensive services you're describing, but beyond that, parenting support, that they need to be mainstreamed in parenting support programs. Many of our trials, myself included, exclude children with developmental disabilities, partly because the institutes that are funding us make us define our samples. But there are ways to broaden. Would you like to see parents of autistic, of fetal, Fragile X, and some of the other things, included in ways so that they're included in parenting support beyond the treatment services they need?
So, again, a great question. And what I would say, I like the word inclusion better than mainstream. I think that it goes beyond. So I think you raise a great point about including a variety of families of children with disabilities in parent support training. But I think they need to, their task is more challenging to learn how to engage their child and support their child's learning. So they need more support than many of the programs that you're describing, unless we can catch them early. Then I think by kindergarten they're all ready for these other programs. Secondly, we need to include them in everyday places in the community. So one of the children that I showed you when he entered, I showed you photos of when he entered our project, the parents couldn't even get him in the car or take him anywhere safely. We taught them how to take him out, starting with the backyard and putting the orange cones and tape to give him boundaries of where to stay. We taught them how to do that and then put a golf club in the car because he loved golf clubs. And then go in the car. By 18 months of treatment, they were able to take him to Walmart and video it themselves successfully. And going out to restaurants and the library. And so there's all these community places, the grocery store, that are phenomenal learning opportunities that parents are going. Often parents of children with autism feel restricted because they don't feel like they can take their child out without creating a scene or it not being safe. So we need to change that as well. And if we can get in early, we can teach parents how to do that.
Thank you. Dr. Ogden, the last word.
Reminds me of a song in Englishman in New York, a Norwegian in the United States. To put it very briefly, I think what impresses me when I come to America is the breakthrough. You're cutting edge on research. You're developing new programs, new methods, new approaches. That's highly impressive. So we come to you for inspiration. You're not that good at carry-through. So when you're going to implement these programs, models and approaches, you export them to Europe and Norway and other countries. And I think what is lacking is some kind of implementation infrastructure in the United States. So in a way, your own children and youth could benefit from your tremendous high-quality research.
Thank you very much, and let's give the panel a hand again. And now we have a 10-minute break, and then we'll reconvene, and thank you.